And good afternoon. Thank you so much for joining us today on today's Tuesday topic. And the topic today is actually called Stranger Things. And it's really about a patient with relatively refractory hypothermia. So it's a simple case study with a lot of great kind of oversight and overview. Stranger Things, extreme hypothermia. All right, so first and foremost, this is about a 62-year-old female patient who presents to the emergency department. Now, that patient's been transported from a prison. So already that makes it a little bit more difficult for us because we don't actually know what went on prior to her coming. This is the direct note, found to not be responding appropriately. This is the first physician note, looked like it was in the triage at on 2/20/2024, just a few short days ago at 10:31 at night. Now, they were very concerned, EMS was very concerned, the physician as well. Patient has a low GCS, it's around 6, can't communicate any concerns, can't talk about pain or anything else at this time. And on first view, patient has severe bradycardia, but airway is intact, she's breathing okay. But then it becomes obvious that the patient is hypothermic. So in the triage or in the ambulance bay, they're noting that the patient is hypothermic. We'll come back and look at that temperature in just a second. So labs are obtained, and of course, the note comes a little bit later. Patient has hypernatremia and hyperchloremia. Usually we see those two things together, not in dehydration, but typically as a result of too aggressive normal saline resuscitation. May or may not be related to dehydration. Doc says, yeah, this is most likely related to dehydration. The patient's already received some fluids at this point. And a CT of the head shows that there's no acute intracranial abnormalities. So we're not really sure what's happened, but I'm pretty positive, even though it wasn't listed here. We've got a lot of things going on with this patient. And remember, you're in the ED, you've come from prison, don't have a great history, and we're thinking about all the things that this could possibly be. So what we don't know, and that's the thing that's so fantastic about how the ED can ever even figure anything out. What we don't know is how long this patient was kind of down and out and altered. We don't know her medical history. We don't know her medication history. We don't really know what her baseline status is, even though they say, well, she could respond before, but we're not really sure how responsive or how with it she is. This is the prison. And was she using illicit drugs? So we have a lot of things we have to figure out. It's a lot different than when patients come to the ICU. We already have kind of a list of this stuff. We already have some idea about what's occurring. Here, this patient comes with altered mental status into the emergency department. We don't really know very much about her. But remember now what time she's come, 23:21. So the doc has written the note, that admission note must be a little later because this is the first temperature that's done, 28.8. That's a bladder temp, okay? So that's not axillary. It's not, under the tongue. It's not a forehead one. This is a bladder temp. So this is a core temperature, 28.8. Oh my God. And the patient is very bradycardic, which is always to be expected with significant hypothermia. Now, looking at the number 28.8, I would immediately call that severe hypothermia. And that's how we would categorize that. That is severe hypothermia. On paper, it's severe hypothermia. And we're going to expect bradycardia. We're going to expect some cardiac dysrhythms. We're going to expect some cold diuresis and some other things that will go along with that if it is actually severe hypothermia. Okay, so you can see respirations seem to be pretty normal. Blood pressure is pretty normal. MAP is looking pretty good, but patient is severely hypothermic and bradycardic. Okay, so for me, there's a couple things that I always think are important for us to point out, which is that you are cold and you are bradycardic. I'm going to be checking your vital signs at least once an hour, and I'm going to be monitoring your temperature. Well, that temperature actually is really easy. We've got a bladder temperature, so we can just really evaluate the temperature pretty easily. Maybe there was some issue with the self-population. I don't really know. All I can say is I didn't really see that temperature being monitored as frequently as I might like until the day shift. Okay, so what happens when you have hypothermia? Well, number one, most importantly, you're going to have some significant cerebral depression, 6 to 7% decrease in cerebral metabolism for each one degree Celsius decline in temperature. Now, we use that to our advantage when we talk about targeted temperature management post-cardiac arrest. We want to decrease cerebral metabolism to put you into cerebral protection. But this is not controlled hypothermia. This is incidental hypothermia. Patient comes to us really cold. How long was that patient in this state in her prison cell? Was she on the floor in her prison cell? Is that why she's so cold? We don't know any of that. All we know is it's 28.8. We also really have to appreciate severe, significant cardiac involvement. Patients will initially present with tachycardia, but then they rapidly become bradycardic. Their pulse pressures decrease by about 50% at 28 degrees Celsius. Remember, she's 28.8. And the cold temperature actually causes a reduction in what we call automaticity or spontaneous depolarization of pacemaker cells. Now, really important to note about this, in a hypothermic bradycardic state, patients are refractory to atropine. We don't utilize atropine. Now, in this case, the patient did get some atropine, but atropine is not the drug of choice. Really, epinephrine is the drug of choice in somebody who is hypothermic. So at some point, there's some discussion between the nurse and the intensive care admitting team. Atropine is at the bedside. Atropine is administered. Doesn't have great effect, and that's okay. We just want to remind ourselves that when we see bradycardia with hypothermia, atropine is typically not the drug of choice. Now, of course, cardiac output, index, stroke volume, etc., and mean arterial pressure. Oh, yeah. Thank you, Jessica. I appreciate that. Are all decreased. So that's not terrible, right? Patient is hypothermic, so overall metabolic demand is slow. Patient is very sluggish. She's had a change in her mental status. She's not highly active. She's not consuming a lot of oxygen. So MAP, cardiac index, stroke volume all go down. Usually that's okay. But because of the instability of the cellular membrane of the heart, it is very normal to see atrial and ventricular dysrhythmias. And under 28 degrees, it's quite common to see ventricular fib or torsade de pointe. Thank goodness we didn't have that happen, as far as I could see, with this patient. Now, as hypothermia worsens, what we typically see is a prolonged PR interval, and then the QRS gets a little wide, and then the QT gets wide. And of course, as the QT becomes wider, that's what puts us at risk for VFib and torsade de pointe. Really important to remember in this situation that you want to be very careful if your patient is having dysrhythmia about the utilization of amiodarone, which will propagate the prolonged QT and put your patient at even more risk for VTAC, VFib, and of course, torsade de pointe. So we always want to be aware of that when we're looking at our patients. Okay, so also really, really important is that when patients are cold, that will actually support a high level of filtration at the glomerulus. So it's not really cleansing of your toxic waste products. It is just high levels of filtration and very, very significant diuresis. And that's going to happen regardless of the state of hydration until the patient is so profoundly dehydrated, and then the urine output decreases. And that actually is what happened to this individual. Again, remembering that, you know, this is not your sister or your mother who you're checking on every day or every hour, who you live with. This is someone in a prison cell. So how long was she cold? How long was she diuresing? And cold diuresis is inevitable when somebody is cold. And of course, there are two really important things about that. she's diuresing somewhere else. She almost urinates herself to death. And when patients are under our care, because we're in love with urine and we love to count those cc's of urine, but it's really important to appreciate that that cold diuresis doesn't really clear toxic waste. So you might be making a lot of urine, but you're not clearing toxic waste, and that's really, really important. So I always want to remind you that the kidney as a whole is primarily receptive and requiring a certain amount of blood flow. And blood flow to the kidney maintains kidney function. The tubes of the kidney, which actually consume a very small amount of the total blood flow to the kidney, are very oxygen dependent. So when we see that renal blood flow decreases, as we do when someone gets cold, of course, they're vasoconstricted, trying to preserve core temperature. When we see that happen, it means that they are significantly at risk for renal infarct. Now, all these things are important to just be thinking about when you get a patient who is cold. Now, we don't know how long this patient was cold. We don't really know what her state is, but as she comes to us, she is profoundly dehydrated, can't collapse. Her IVCs are completely collapsible. She's very dehydrated, but because she's cold, she's not tachycardic. She has a bradycardic heart rate, which is totally bizarre because she really is in hypovolemic shock. And in addition to that, we always have to consider, as we would on every single patient, think she's probably hypovolemic because she's had cold diuresis. We don't know how long, but what we do know is we put in a Foley catheter and she isn't making very much urine, and she should be making a lot because she's cold. So our assumption is she's already really almost urinated herself to death. And we're going to consider hypovolemic shock. And we also have to consider that one of the causative factors might indeed be sepsis. So again, kind of the first thoughts are with severe hypothermia, no big surprise that she's sluggish and had a big change in her mental status. Also, no big surprise that her heart rate is bradycardic. That also means, remember that normally when your heart rate is bradycardic, your stroke volume goes up. But in this case, stroke volume goes down as well as heart rate. Her blood pressure can go down. You know, we don't know her. So maybe her normal pressure is 180 over 100. She comes to us, it's 110 over 70. We think everything's right with the world because we don't have a history on her. Remember, dysrhythmias might be present. Her lungs may become congested. She may have very significant cold diuresis followed by oliguria as she has wasted her water. And it's also very common in hypothermia to see areflexia. Now, that's really important because the absence of reflex is also something we're going to use to look at another condition, and that would be hypothyroidism. Now, in the end, sustained hypothermia can lead to cardiorespiratory failure. And then, of course, we have the whole adage of we've got to warm you up so that you have stabilization of your cellular membranes so your cardiac function can become more regular. Okay, sorry about that. Not sure why it won't go forward, but there we go. So first thoughts are, is this exposure? Was she on the ground in her cell? Was her cell cold? Had she been wet? We don't know anything. Secondly, does she have some type of neurologic issue that has promoted diabetes insipidus? And we often will see diabetes insipidus, neurologically caused diabetes insipidus with hypothermia. So that's got to be a question right away. And our thoughts are, we really don't know about the exposure issue, and we can't really find any information about that, unfortunately. But we're going to do a neurologic evaluation, do a head CT, probably do a cerebral MRI, just to make sure that this is not a neurologic mediated event, diabetes insipidus. Hypothyroidism. Oh my God, you guys, I just think it's such an important thing for us to always consider thyroid function. Thyroid hormone affects over 400 activities in the human body. And when we talk about hypothyroidism, it makes it really, it really makes it simple to say when thyroid hormone is low, heart rate will be low, temperature will be low, blood pressure will be low. And again, her blood pressure may be relatively low for her. Typically, glucose is high because you're not metabolizing it in hypothyroidism. And in severe hypothyroid states, things like myxedema coma, which actually can occur for the very first time that we are actually making some assumption about a person's thyroid state. They may never have been diagnosed with a thyroid disorder. They come to us in the ED, they're cold, they're bradycardic, they're relatively hypotensive, they are mildly to moderately hyperglycemic. We should always be thinking about hypothyroidism, and that's something we have to be thinking about immediately when we have somebody come in who's cold. And that's because if you have any degree of thyroid dysfunction, you cannot be rewarmed actively. You can't get an Arctic sun, you can't get a bear hugger. It puts too much burden on your hormonal state and can actually facilitate death. Okay, we're also going to remember that in individuals who are receiving diuretic support, as they diurese, they can become mildly to significantly hypovolemic. They vasoconstrict, that shifts their blood flow away from their periphery, and their periphery gets cold first, and then the core gets cold second. And then, of course, DKA, diuresis, and shock associated with DKA, probably most significantly related to either hypothyroidism or adrenal insufficiency. So I want to make sure what you're hearing from me. I don't expect everybody to remember all of this. I won't remember all of this. What I want you to remember is that when you have a patient who is hypothermic, I mean, we live in Georgia, but if you're laying on the ground in Georgia and it's 40 degrees out, you can have hypothermic shock. That's for certain. But we must always incorporate in that evaluation, should always be an acute endocrine evaluation, and that we should be asking for that at all times. Now, the other thing that it could be, or that we can think about, there's many disorders, Paget syndrome, lots of different disorders, but one of them is Wernicke's disease. And Wernicke's disease primarily occurs because you have an absence of thiamine in your diet. Okay, so then we go back. Well, I'm not saying you all have great thiamine levels either, but we go back to the fact that she's in prison. What is her vitamin B12? What is her thiamine? Those types of things can also lead to significant and profound hypothermia because of hypothalamic dysfunction. Again, hypothyroidism, hypoadrenalism cause hypothermia, burns, dermal disease. We're not worried about that. We're not worried about extreme age here. She's 62. We don't know if she had any illicit drug use, probably not alcohol, but maybe some other illicit drug use. She is in the prison. It is available. It is possible. So these are all things that your ED doc and your APPs are all thinking about when that patient comes in. And I just say, I don't know, she might have Wernicke's disease. You have to look at thiamine in her vitamin B12, by the way, which no one has done even today. Okay, hypothyroidism and hypoadrenalism, everybody looked at that. We know she didn't have burns. We know that she doesn't have extreme age. We don't know what agents she used, if she was using agents, and that's pretty easy to rule out. Get a tox screen, which she did. Okay, now what she looks like versus the definition. Okay, so moderate hypothermia, stupor, delirium, slow reflexes, some dysrhythmias, and by the way, inability to rewarm. Can't rewarm by yourself. And as I try to help you rewarm, it's still going to be pretty difficult. Severe hypothermia, by temperature, she looks like she has severe hypothermia. But when we look at our patient and we have an appreciation for how she actually looks, she does not meet criteria for severe hypothermia. She has heart rhythm, cardiac arrest, loss of voluntary muscle control, urinating in the bed, having a bowel movement in the bed, low blood pressure, undetectable pulse and respirations, and she's in a coma. So I think based on the excellent note writing of the day shift nurse in the ECC, I believe that she meets this criteria, despite the fact that by temperature degree, when she first comes in, 28.8, she looks severely hypothermic. Now, we rewarm her somewhat, not somewhat quickly, but we rewarm her within a few hours. She's at 30 or 31 to 32, and then she gets cold again. But I think she may have spent a little bit of time in severe hypothermia and then went into moderate hypothermia. Now, this is her EKG. So I just want to mention some of the things you look at in somebody who is hypothermic is, do they have a prolonged PR interval? So you can see here, it's about 6 boxes, so 0.24. And even the computer agrees, prolonged PR interval. She's got a little bit of T wave abnormality. I'm not worried about that, or ST segment abnormality, a little bit in her lateral leads, AVL, lead 1. She also has it in her inferior lead, lead 2. So I'm not really looking at that as an indicator of STEMI, but I also want to look at her QT. So you can see, normally I don't leave all this information up here because I'd rather you figure it out. She's a female, so normal QT, and that's QT corrected, normally would be less than 480. And indeed, she is less than 480 with her QT corrected. And you can see QT corrected is much lower than her actual QT because we've factored into this now that her heart is beating slowly. She does have a secondary wave here, and that I would call this. So here's what I think is her T, and here I think is what we would probably call a U wave. And that is also indicative of hypothermia. So I'm paying some attention to this because I'm a little concerned. I'm going to be all over this patient in terms of cardiac monitoring. I'm going to make sure I'm doing an appropriate QTC by my bedside monitor. I'm going to be very careful about any medication that might prolong her QT. Because I think she's really at risk at this point in time. She's really at risk for ventricular arrhythmias. Now, this is not her. This, you can see, I downloaded this. This is actually what we call the Osborne wave right here. The Osborne J wave. So it occurs at the J point. It's that second, it's like a second depolarization because of the instability of the ventricular cells because of the hypothermia. I have to tell you, I've only seen this in my career, which spans 46 years. I've only seen this twice, and I worked in trauma for a really long time. So I haven't seen it very much. And I worked in Massachusetts where it's really cold and we would resuscitate and pull people out of snowdrifts. So I've only seen it twice. There's always a lot of discussion about it. Any test you take talks about it, but it's not that common for us to see. Now, this is her chest x-ray. Her chest x-ray looks pretty great. She's got a little bit of infiltrate there, but nothing to be worried about. She really looks good by her chest x-ray. And then we look at her first set of labs. Okay, so this is her first labs in the ECC. You can see that her sodium is a bit elevated. Potassium is okay. Chloride is elevated. And bicarb is normal and her GAP is normal. Kind of looking okay. She's a little, her glucose is a little bit low. I think that's probably from malnutrition. I would have loved to see a thiamine level at this time. I didn't see one when I looked through all her labs, but you know, I could have missed because she's been here for a bit now. So lots of labs, but her creatinine looks beautiful. Her BUN looks fine. So from my point of view, this doesn't look to me like dehydration. I think the fact that she's hypernatremic may not be necessarily related to her volume status, but when they were doing her POCUS, they were pressing on her IVC and it did compress, which makes us think that the volume an issue. And of course, her liver enzymes are a bit elevated, but overall, her labs look pretty good. Oh, this is making everything so much more confounding. Okay, second physician note. Remember, she came at 10 p.m. on 2/20. Next note, 4:06 a.m. I'm not going to refer much to the nursing notes for the night shift because they weren't very informative. It doesn't mean that the nurse wasn't doing a great job. They're just not that informative. So again, we see now we discover something else in this note, bipolar disorder. Okay, well, some of those medications can actually induce hypothermia. So could that be part of it? Perhaps. And again, you know, she's not responding appropriately, different from her baseline. I always think this is so interesting. Patient's last known normal is unknown for the officers at the jail. Well, wait a minute, then how do we know she's not responding appropriately? I mean, she's not responding appropriately. How do we know that that's different from her baseline? The jailers say, we don't know. Well, like when was the last time you saw her? And was she laying on the floor for 2 or 3 days? We don't know. Was she laying in a puddle of urine, which made her even colder? We don't know. I mean, these are all things I'm thinking about, but I don't know. Okay, so in the ED, we see, of course, bradycardia, hypothermia, and hypotension, nonverbal. She raises her arms. She doesn't respond. Dehydrated on exam, IBC shows up to 50% collapsibility. Her blood glucose is 86. So they're doing a fantastic job looking at this patient. Her white count is 3.5. Okay, now when we talk about somebody being septic, our desire is for the white count to be elevated because that's really clear and is quite straightforward. But patients who have been hyperinflamed with sepsis for a couple of days, they will consume all their white cells, so the white cells now decrease. Her lactate is normal, her UDS is negative. She has trace ketones, 1% hemoglobin, 2% bilinogen. So, but her head CT shows no intracranial abnormalities. So now we're ruling that out. We don't think it's diabetes insipidus, okay? Not sure what it might be. She got 0.5 milligrams atropine ET for bradycardia, that's fine. Got another liter of lactated ringers. Her blood pressure and her heart rate continue to decrease. Okay, now why is that? I mean, I'm not telling you I can answer that question. Does she have some kind of sympathetic stimulation failure? I don't know that, okay? That hasn't yet been evaluated, and she's been here for a bit. She got another liter bolus of LR, and she was placed on the bear hugger. Look how cute that is from the physician. I like that idea. A bear is hugging me. It's BAIR, but that's okay. Bear hugger sounds great. She's going to be admitted to MICU for her moderate hypothermia and shock. So at this point, she's on norepinephrine and vasopressin for her. She has become hypotensive. She's on max 27 of norepinephrine and vasopressin. So if she wasn't cold before, she will be now, because now all that vasoconstriction actually limits her ability to deliver blood to the periphery and make her a bit warmer. Okay, well, she needed those vasopressors. So the next thing I'm going to think about is hypothyroidism. Well, for me, okay, so her TSH is 3.85. Here's the thing. TSH is not enough. And that's something to always remember. You really need a free T3 and a free T4, because TSH in general in predicting thyroid dysfunctions is a really great tool for a global overview. But this patient is confounding. So we really actually need an endocrine consult, which she never got. And she should really have a more full evaluation of her endocrine, of her TSH and her thyroid hormones. Women have a lot of variability. They don't always follow the rules. Women post-menopause oftentimes will have hypothyroidism that you cannot define by TSH, T3, and T4, that you actually have to look at thyroid antibodies. So from my point of view, I still, at this point in her stay, I still want to know what caused her hypothermia to begin with. And there has not been an answer for that. But regardless, we're looking here to say, okay, this is what's been done. We're in the ED. TSH looks good. Don't think it's hypothyroidism. And don't think it's hypoadrenalism. Of course, her cortisol levels are normal. And think that probably not hypothyroid, hypoparathyroid, because her procalcitonin levels are normal. So she's gotten a very nice global scan, way, way more intense than you would ever expect any emergency department to do. Bravo to the emergency department. They were really trying to figure out what was happening with this patient, and they're doing it pretty quickly. Patients staying in the ED for a little period of time, but they're doing a really nice evaluation. Now she gets on 2/21/2024, she at 5:50 a.m., she gets an A line, she gets a central line. She also, not at 5:50 a.m., but she's also completed a head CT, and I just want to make sure we just took a look at that. No acute intracranial abnormalities, so we've ruled out the belief that this is diabetes insipidus, although it could be renally induced, but probably not, because her kidney numbers look really great. But I love that the radiologist said, please note, you really might need to do an MRI because this doesn't look abnormal, but it might be really important to do an MRI. Okay, now we go forward in the ED from 2 a.m., right? So 29.8, 2:30, 30.4, bradycardia, and then through into the morning, okay? And you can see 32.1 at 5:05. Doesn't get another temperature probably until the day shift comes. She continues with her bradycardia, and her blood pressure, as you can see, has dropped here at 230. That's why she went on norepinephrine and vasopressin. And she kind of just continues really to befuddle everybody, right? She's hypotensive, she's bradycardic, she's hypothermic, and she kind of spends the night being, I think, relatively hypothermic. Okay, fourth physician note, each physician note, so interesting because you get a bit more information, some of which is in a direct conflict with the other. This one looks pretty good, right? Bipolar from the prison, don't know how long she was hypothermic. She's lethargic, she can protect her airway, normal respiratory, normal heart sounds, normal breath sounds, no edema. And the differential diagnosis is metabolic etiology. So again, hypothyroidism, hypoadrenalism, etc. Does she have seizures? So maybe she was having seizures. So she also gets a neurodiagnostic in a moment. We'll talk about that. And it says she doesn't take medications in the prison. But wait a minute. Wait. You have a patient who has a bipolar disorder and they're not taking medication in the prison? No, I don't think that's right. I think she is taking medication. I just don't think we know what it is. And later we discover one of our APPs has a discussion about the medication that she takes in prison. That is for her bipolar disorder. Okay, so really important kind of all this communication and coming back and forth. So she gets ultimately 3 liters of IV fluid and then gets a fourth. POCUS in the morning shows volume depletion, but later they feel like it's better. She continues at bradycardia, norepinephrine, vasopressin, going to give her some stress dose steroids. That'll be 100 milligrams. And not in respiratory distress, not eating, no signs of bleeding. Everything looks pretty good. Glucose at goal, TSH is normal. Looking kind of okay, except she's cold and bradycardic and hypotensive. So now I'm just taking little bullets from the daytime nurse who happens to be on the call. She documented what was happening for her patient. I'm just taking some bullets. So nurse documents that her temperature dropped, the patient's temperature dropped. She applies the Arctic sun. So throughout the night, the patient's cold. I'm not sure what, she might have had a bear hugger on, but on the day shift, they place an Arctic sun. So we put on the Arctic sun, and as we're trying to rewarm the patient's temperature drops. She also connects the central line for monitoring and documents her CVP of 2. Now, you might remember CVP is not a volume measure except when it's below 5. If it's below 5, you are always hypovolemic. Nurse also reports that the patient has a poor urine output despite all this fluid loading. They've added more volume. Now patients had 4 liters of fluid, but patients having a poor urine output in response to the amount of fluid she's received. She could just be that darn hypovolemic. Next report of the CVP, which is a couple hours later, next report is CVP is 6. Okay, so I know this nurse. I know she was sure there were 300 millimeters in the pressure bag. The patient was leveled and zeroed. I know that she did this all correct. Again, I said this again, the nurse reports a drop in temperature after warming has begun. And that's really upsetting. Like, wait a minute, I'm trying to make you warm and you get cold. I'm trying to make you warm and you get cold. And then the patient transfers off after that daytime nurse has left at 10:30 at night. So I want to just remind you about something that you don't see very much, which is why you're not thinking about it very much, because you live in Georgia and we don't see that much. We see some incidental hypothermia, not the same as the hypothermia that occurs with patients who are septic. But when we've had patients who have had significant drops in their temperature, particularly because of exposure, as we actively externally rewarm them, they will peripherally vasodilate, blood pressure is going to drop. Everybody who takes care of patients post-op knows that. Everybody who takes care of CTS patients who come back from the OR, we know that as we rewarm, or as the patient even rewarms themselves, they will vasodilate and drop their pressure. Number one. Number two, when you dilate your peripheral vessels, cold blood from the core actually distributes to the periphery, and that drops your temperature. It's called after drop phenomena, something we used to look at all the time when we had patients who had significant exposure and would come in with temperatures of 30, 32, 28, 25, if we were in Alaska, 18, whatever. But this core redistribution of cold blood can actually be really serious, because it also redistributes lactic acid. So her initial lactic acid was kind of low, and then it went up, really related to this after drop phenomena. So the idea is that you got to rewarm really slowly. So I think initially the rewarming was probably set at about 1 degree. I think that's what I read. And what you have to remember is if your patient drops their temperature when you're doing it, or becomes more acidotic, or drops their blood pressure, you have to reduce the level of rewarming. But there is something else that's really, really important. So just want to remind you, core temperature after drop phenomena, not uncommon when you've got somebody this cold. Could result in VFib, could cause very profound, and thank goodness it didn't, cardiovascular collapse, and also very significant acidosis, and can really cause a cardiac dysfunction. So the general, I'm so sorry, I thought I had it there. Okay, but I don't. So what I'm going to just say is that the general recommendation is when you are rewarming a patient, you do external and internal rewarming at the same time. So what that could mean is you're giving warm fluids. You could be doing warm lavage. You, if the patient was intubated, which of course she's not, is you would turn that temperature up on the humidifier on your ventilator. She's not intubated, but she does experience after drop phenomena, because the nurse reports multiple times, as I'm rewarming her, temperature keeps dropping. Now, her temperature keeps dropping, and she also drops her heart rate, which actually indicates to us that her cold heart is not yet able to compensate. So at this point, just in the future, I would just say, I'm going to stop here. I'm going to reduce my rewarming potential from 1 degree to 0.25 degrees. And then I'm going to talk about internal rewarming. Now, the highest level of internal rewarming is CP bypass, cardiopulmonary bypass, or ECMO, or other types of cannulation. But we can do gastric lavage with warm fluid. This patient's not that critical, so it's kind of confounding for us. She really was on the edge of being profoundly critical, and she does kind of get a little bit worse. So now we look at the APP note in MICU 222 and 223. By the way, cut and paste, same note. It's so amazing. The only thing that was different was the labs were a little different, but the whole note was exactly the same. It was just cut and pasted. So in ED, we know what happened in the ED. We know she got good care in the ED, strong vasopressors transferred to the MICU. In the MICU, she's lethargic, almost somnolent. She responds to painful stimuli. She's getting worse, actually, not better. Not opening her eyes, she's not tracking nor following commands, but she still is protecting her airway. Doesn't require intubation. Remember, she's on norepi at 27. Now epi has also been added. The art line was dysfunctional, so that was replaced. Vasopressin is on as well, trying to wean epi and norepinephrine cautiously. Don't think she's got cardiogenic shock, because SCVO2 is 73. Normally with cardiac shock, that's going to drop. She doesn't have cardiac shock. I think she has septic shock, and I think she has hypovolemic shock. She just doesn't have any lung involvement at this point in time. But now we say, whoop, we definitely have some hypoperfusion abnormality, and her potassium has dropped, mag is low, phosphorus is low, creatinine is acceptable. So she gets all sorts of replacements, and so on and so on and so on. She gets a neurodiagnostic, no seizure or clinical events. She has no pulmonary embolism. And on 224, this is her problem list. Oh my God. it's such a problem, right? She had low mag, she had low phosphorus, she had high sodium. That's all resolved with fluid replacement and electrolyte replacement. Ketones on admission in urine, but her glucose was normal. She may have had euglycemic ketosis, but her gap wasn't wide, so that was kind of a bizarre thing. But most importantly, see this, see, in the jail, she is getting medication for her bipolar disorder. So again, that's really important. We may or may not be familiar with those medications, but we always have to consider them in conjunction with what's occurring here. Never did a thiamine evaluation, but did do a vitamin D evaluation, and her vitamin D levels were low. So you can see she has a very long problem list, but we still haven't, there's nowhere. I read every single physician note, every single APP note. There's nowhere in the list that explains why she was hypothermic. Now, this is a standard ED hypothermic care algorithm. So your patient comes in, they're hypothermic. Big decisions are you under 30 or are you at or over 30? Okay. So under 30, really, really important. Got to do internal rewarming as well as external rewarming, because the problem is the heart is so cold that it is not able to adjust as you dilate the vessel during external rewarming. The heart is not going to be able to adjust. This is just a basic, is actually from the gosh, I'm so sorry, the National Organization for Emergency Medicine for physicians. This is from them. It just says, just remember, when somebody is that cold, don't just rewarm them externally. You must also rewarm internally, and you do that at the same time. So here's where we are today, right? Acute encephalopathy, bradycardia with undifferentiated shock, still has leukocytosis, acute respiratory insufficiency, although really not so much so. She's on 2 liters nasal cannula. I don't really feel like that's respiratory insufficiency, but I'm not writing her note and I didn't look at her. So urinary retention now, which has actually been a problem. She's getting a lot of straight casts in and out, and thrombocytopenia. So here's the thing. Don't really have answers for you. The only thing I can answer for you is, why is it that her temperature dropped every time you tried rewarming her, which I believe was after drop phenomenon. I don't know that we've investigated all of the endocrine deficits that could have caused this problem. And also because, the issue of her initial hypothermia actually resolved, there must not be something that's underlying promoting that hypothermia, and it might just have been exposure. But I think the fact that we did a good endocrine evaluation, and we have to continue doing endocrine evaluation, is critically and profoundly important when we're looking at those patients. So I want to just say thank you very much for attending today's Tuesday topic. I'm going to sign off from the recording, but I'm going to remain on the line for my colleagues who are listening. Thanks so much. See you next time, and goodbye for now. Always do that. I'm looking at there we go. That's the problem of getting old.